thing, I have two questions for the panel. One is, and I don't want to get into the role of surgery in stage 3 disease, particularly the 3A disease, because my personal bias is that there's a very limited role of surgery in 3A disease. It's a chemoradiotherapy disease, but surgeons will argue, and some others will argue about that. Does this data influence like who you might consider for surgery versus not surgery, or it's just a different argument?
So I think we have now good data to do our chemo radio IO thing. Yeah. So I think it supports that we try to avoid a little bit more surgery than we did before. This influences, but you have to put that sometimes away because you have the surgeon also in the tumor board.
Yes.
Who would say, I want to do surgery,
yeah.
But this helps us to be more on the side of the non-surgeon part.
Right.
For us, we have a sort of a very disciplined group where the people we took to surgery were generally single-station microscopic N2 disease, fought with an induction therapy. Many of them also got post-operative radiation therapy, or at least a referral to radiation oncologist. Right. So it doesn't really change our strategy at this point.
Yeah, because you were limiting surgery to the low-volume, single-station sort of things. Others?
Yeah, no, we were the same. We did local induction chemoradiation. But it's the rare patient. The majority of patients are not being considered for surgery. They're chemoradiation and durvalumab.
Yeah, and from a radiation oncology point
So from the national patterns of care in Holland, we've decreased surgery tremendously, but this would be an extra reason for not to do it. Yeah. But we do it for selective patients where you can do a lobectomy, single station, low volume disease. Yeah. But then there's a question based some of the animal work suggesting that actually in animal models, if you do a surgical procedure, the micrometastases are actually stimulated.
Yeah.
So it'd be interesting to see the adjuvant surgical trials, how they read out and what their control arms are going to be versus the IO arms, where there's going to be much of a difference.
And then the other opinion I wanted to get from the panel is, I believe in Pacific, 6% of the patients had EGFR mutation positive disease that were included in this trial. It's a very small subset. I think that was one of the widest confidence intervals I saw on the forest plot in terms of those EGFR mutant patients. But what do you do in practice? If you had an EGFR, I mean, maybe we shouldn't be testing in stage 3 disease, but let's say you do, and you have an EGFR mutant patient, would you apply the Pacific data to an EGFR mutation positive patient?
So I think that they're a harder group of patients to know what to do in. The progression-free survival data wasn't positive. The OS data we don't even know because the numbers were so small. And I do worry that these IO agents are not effective in first line. We've seen with Eddie Guerin's data, they're not that effective. Second, third line from all the Keynote Checkmate studies. So it's a discussion to have with those patients, because the other thing you worry about is when they do progress and you give them a TKI.
Hopefully they don't.
But unfortunately, I think hazard ratio is good, but not perfect. But you give that TKI, and then they have enhanced toxicity from the TKI.
Yeah. I mean, is there? But the question is, does the chemoradiotherapy alter the immune milieu, if you will, and create a different situation than we've typically seen with the data of monotherapy in second line with EGFR mutants and that sort of thing? And I don't know that we know the answer to that.
I think it's that discussion of, I don't know that this will help you, but I don't think you're harming the patient by doing it.
Others?
So from my point of view, we are testing in early stages also. So when we do bronchoscopy, we do the whole panel, and we don't say stage 4, we test or we don't test. So we get the EGFR mutation testing immediately, like in all patients. But we also have data for like a phase 2 trial, Ascent trial with afatinib as an induction treatment 3 months before the chemoradiotherapy or the combination with surgery. So I think in this situation, we should think to do an induction also with EGFR TKIs in this situation. And I think, like Dr. Horn said already, that EGFR mutated patients do not so have much effort of IO in this situation. So I would avoid IO in this situation generally and try to get anyhow a TKI in this early setting.
I mean, I think to your point, we don't have enough data to say one way or the other. It's a discussion. I think you can go either way. Suresh?
I think we've had this debate many times, and we would now, if it's stage 3, true stage 3, we'll go to concurrent chemoradiotherapy, platinum etoposide. It becomes difficult with the with the IO now, whether we should add it or not. But I'm in favor, because it was not clearly negative to do it, because our experience has been when we do chemoradiotherapy in the EGFR mutated patients, they tend to do badly. They tend to come back fairly soon, recur. So I think it's because of, we don't know it, but occasionally we have patients where if it's a bulky disease, these are sometimes they start off with a EGFR inhibitor and then refer a patient, and then after the so-called induction phase, we do concurrent. Because it's localized disease, we feel that we shouldn't be treating it the same way as stage 4 disease.